Thank you.
Okay, well, it's 7 o'clock. Um, let's go ahead. So everybody can see the title of the talk. Just one comment. Next week, uh, we're we're off because it's Thanksgiving week, and then 2 weeks from now, the next session will be in person with a visiting speaker. So Karen's going to go ahead with today's presentation.
Thanks, Lynn. Thank you very much for inviting me to speak. It's always, I learn so much when I'm making my talks. I hope this is an informative one for you today. I'll be discussing new developments in inborn errors of immunity. Here are my disclosures, none of which will be relevant to my talk today. The objectives for my talk will be to review key concepts of the 2022 IUIS update on classifications of inborn errors of immunity, sort of our new name for primary immune deficiencies. We'll discuss distinguishing gene variant function and phenotype. And then the bulk of my talk today will be reviewing some key monogenic atopic diseases that I hope will be interesting for our audience today. So there were a couple of papers that were published in 2022 from the IUIS, or the International Union of Immunological Societies Expert Committee. This paper by Stuart Tanguy et al. Is one that helped to classify things based on the gene or genotype. And then the second paper, published by Busfiha, I hope I pronounced that correctly, was one that they used phenotypical classification. And I'll show you some examples of that. And from this group of papers, they always like to show the number of genetic defects involving inborn errors of immunity from 1980 moving forward to 2021 or 2022. So now I think there's over 500 monogenic disorders involving inborn errors of immunity. And another concept that they discuss are phenocopies, so defects involving multiple genes which end up having basically the same phenotype. And just as an example from the Tanguy et al. Paper, which is the genotype paper involving classifications, they provide tables where they group defects in B cell development, like XLA or X-linked agammaglobulinemia caused by defects in the BTK gene, as opposed to gene defects that provide a more CVID phenotype where you may have a normal or low number of B cells rather than absent B cells. So one example of this is PIK3CD gain of function defects, and then way down the list is something I'm going to talk about some more, defects in Ikaros. So within one gene, you can have several phenotypes. And this group of papers from the IUIS discuss that the different types of variants can lead to the different phenotypes depending on whether you have a gain of function mutation, loss of function mutation, whether the disorder is caused by a single allele defect, in which you may have an autosomal dominant or dominant negative defect, haploinsufficiency, or as opposed to an autosomal recessive mode of inheritance where you might have biallelic mutations. And so one example of that is involving Ikaros or IKZF1 mutations. IKZF1 or Ikaros is a zinc finger transcription factor that is critical for hematopoiesis and lymphopoiesis. So monoallelic defects involving loss of function will cause a CID or combined immune deficiency or CVID phenotype. And these patients often have low B cells. And this was a defect that was described in, 2016, whereas gain of function variants were described more recently in 2022. And these patients have immune dysregulation, autoimmunity, lymphoproliferation, They can have increased risk for developing leukemia, a pre-B cell leukemia, and then quite a few of them also have allergic issues. And this was due to Icaros being involved in being important in T and B cell differentiation. And so if you have defects in gain of function in Icaros, then you can have this lymphoproliferative issue along with atopy. And so here is a table from the second paper, which tries to classify things based on phenotype. So in this really large table that reviews different causes of hypogammaglobulinemia, in which you may have low IgA, IgM, or IgG. However, you may have still with some B lymphocytes that they list Icaros haploinsufficiency. So this is the loss of function phenotype where you have recurrent infections. And then in another table, table 4, are diseases of immune dysregulation. And down here, they point out Icaros gain of function mutations. So these patients have a lot of autoimmune disease features. And then this is a table that is taken from that 2022 Science Immunology paper where they described 4 families, 4 unrelated families, all with mutations or gain of function variants in this position, amino acid position 183. And 2 of these families had an autosomal dominant mode of inheritance, so family B and family D. And then 2 of the families, family A and family C, had these spontaneous mutations that appeared in one of the generations. So you can see that there's a significant number of patients who had this autoimmune or immune dysregulation phenotype, where they develop a lot of autoantibodies. They could even develop an IPEX-like syndrome where there's endocrinopathies like diabetes, Hashimoto's thyroiditis, along with vasculitis and autoimmune hepatitis. Some of the patients developed alopecia and vitiligo, so skin issues, and then a number of them, but not all, had atopy and allergy problems. There was one patient, B3 in this family, who was completely asymptomatic, although this patient did have abnormal laboratory values, even though there was no significant disease symptoms. And then they ended up treating these patients with some of our immune modulatory therapies like rituximab to reduce those autoantibodies. Some of them that had increased infection issues were treated with IVIG. And then there was one patient who ended up getting hematopoietic stem cell transplant. There was not a lot of data about the outcome of these patients after treatment. So hopefully there's going to be more papers that will come out from that. So kind of shifting a little bit more to atopy, I looked up the definition of this word, and this term atopy stands for the genetic predisposition to develop an allergic reaction that produces an exaggerated IgE response when a person is exposed to otherwise harmless environmental substances. And as we all know, this is our field, so allergy-related diseases affect at least 30% of the population and 80% of families. And the NHIS 2014 health interview survey identified that at least 8% of US children under the age of 18 suffer from allergic rhinitis, 10% have respiratory allergies, at least 5% have food allergy issues, and more than 10% had issues involving the skin, like atopic dermatitis. So historically, we've always thought of atopy as really being a disease of complex mechanisms involving the environment, genetic predisposition, exposures to things, infections. There's been the hygiene hypothesis in which, if you live in a farming environment as opposed to an inner city environment, this may or may not predispose you to developing atopic disease. However, more recently, Josh Milner has coined this term primary atopic disorders, in which single gene defects can result in a high penetrance and development of atopy and allergy in almost all of the individuals who have a variant in these single genes. And we've kind of tried to categorize these into specific altered processes like impaired T cell receptor signaling or aberrant cytoskeletal remodeling, altered cytokine signaling, in which you have interleukin defects or STAT defects, problems in which you have restricted T cell repertoires. So these are genes that are often associated with a combined immune deficiency or a SCID phenotype. Defects involving failure of tolerance. So the classic example of that is IPEX syndrome, where you have abnormal regulatory T cell development. Glycosylation or metabolic disorders like PGM3 defects, skin barrier disruption, and mast cell deregulation. And I'll go into each of these in a little bit more detail for you as well. And then looking at this in a different way, kind of listing all these genes vertically, you can see that some of these defects involving disorders of skin barrier function will also increase your risk for having skin infections and atopic dermatitis development. Cytoskeletal abnormalities, the classic one that I see most often is Wiskott-Aldrich syndrome. So these patients have combined immune deficiencies, development of atopic dermatitis, food allergies, eosinophilia, and high IgE levels. And then my colleague, Eric Allensbach, he has published on CARD11 defects where there's aberrant T cell receptor signaling. And at least in the autosomal recessive form, you can have immune deficiency issues and development of an atopic phenotype. And so on and so forth. And then Josh Milner has published on these phospholipase C gamma 2 defects or PLAD, where patients have temperature sensitive mast cell degranulation. They have urticaria and can present with a CVID-like phenotype. So in one of his, Josh Milner's reviews is, picture describes 1,000 words. So you kind of look at all these signaling defects involving increased risk for developing atopy. So here is that phospholipase C gamma 2 defect where you can have aberrant mast cell degranulation, we don't really have time to go over this in much detail, but STAT5B gain of function defects can result in this loss of T regulatory cells and increased immune dysregulation. And then STAT3 and urban defects can result in aberrant TGF beta signaling, connective tissue abnormalities, as well as, especially in the STAT3 pathway, elevated IgE levels, development of dermatitis, increased bacterial skin and lung infections from staph. And then here we have the group of CARD11, BCL10, MALT1 defects where you can have abnormal T cell receptor signaling, and then actinopathies, which then can result in problems with the cytoskeletal formation. Here, WAS protein. Another phenocopy of WAS includes WIP-F1 defects, and then these patients can have a lot of immune dysregulation, and eventually they can develop malignancies as well. So I'll go into, and then the last thing here is defects in skin barrier function. So we have SPINK5 mutations, which result in Netherton syndrome, which causes really, really severe atopic disease and high risk for developing food allergies and very, very severe eczema. And flagrant defects, I think this was originally described in autosomal recessive or biallelic mutations, which result in ichthyosis vulgaris. But as we know that carriers who have of heterozygous variants in flagrant defects have increased risk for developing atopic dermatitis. and then defects involving the desmosome, so including desmoglein 1. So then you can also have these impaired cell skin barrier issues. So discussing Wiskott-Aldrich syndrome just a little bit more. So this is characterized by this classical clinical triad involving thrombocytopenia and small platelets, recurrent infections, and eczema. Wiskott-Aldrich syndrome is an X-linked disorder caused by loss of function variants in the WAS gene, which encodes for WASP or ROS protein. These patients have reduced WASP protein expression and function, and this WAS gene is expressed exclusively in hematopoietic cells. So we can send for whole blood to Cincinnati Children's, where they can look at this WASP protein expression on flow cytometry, and this is a pretty good readout of whether a patient has a Wiskott-Aldrich syndrome phenotype. And then, as I mentioned before, WAS protein is important in the actin remodeling and cytoskeletal scaffolding within cells. So when you have defects in WAS, you have aberrant synapse formation between lymphoid cells and in megakaryocytes that result in increased risk of infection, and then patients can also have these small platelets that can increase their risk for bleeding. So this leads to this syndrome of immune dysregulation because of the aberrant synapses that are formed between T cells and other cell types. They can have development of autoimmunity, including immune cytopenias, develop allergic disease, food allergy, asthma, and then this is a picture of one of my patients who had pretty significant atopic dermatitis, and then again, increased risk for developing malignancy. So one of my cases is an 11-month-old male who developed facial and lip angioedema after exposure to almonds, was already diagnosed with Wiskott-Aldrich syndrome at this point when he presented very early in life with petechiae. So at 11 months old, he had worsening of atopic dermatitis that was quite severe and refractory to topical steroids, topical immune modulators. And then because he started drooling and having teeth come in, he developed really severe irritant contact dermatitis of the lips from saliva. He would have these cycles where he would be rubbing the lips because it was itchy. He would eat something, the skin would flare up, he would rub even more. And the parents would try to put on topicals and have, barrier to the lips, but it was really impossible because he was drooling all the time and rubbing his face all the time. He had poor weight gain and poor appetite and began to have episodes of emesis several times per week, regardless of food. So then we ended up deciding to treat him with dupilumab, which is a monoclonal antibody against the IL-4 alpha subunit, or IL-4 receptor alpha subunit. And after the first dose, he had improvement in atopic dermatitis and in this irritant contact lip dermatitis. So this is after just one dose. Significant improvement. He had reduced emesis and increased weight gain. So around the same time, we had concerns that he was developing eosinophilic esophagitis. He ended up having an endoscopy, and there were increased eosinophils in the esophagus that did not quite meet criteria for eosinophilic esophagitis, but that was, we think, because he was already pre-treated with dupilumab. However, after...
Can I ask you, what was the rationale? I mean, for using it work, but why did you think it would work? What would the mechanism of the disease, why should that drug work?
So with the dysregulation of cell signaling in Wiskott-Aldrich syndrome, we know that these patients are prone to developing pretty severe eczema, which then leads to developing food allergies, and then having the eosinophilic esophagitis kinds of symptoms that were developing. I didn't show all his labs, but he had a significant eosinophilia, elevated IgE, so was prone to kind of having this Th2 sort of phenotype, in addition to the background of the immune deficiency and small platelet issue. So I figured, well, he's already maxed out on topical therapies. What else can we do? Let's just try dupilumab. And it did seem to help. So it was, kind of using what biologics we had that were safest. And by this time, dupilumab, was FDA approved for kids 6 months and older. So I thought, well, there's enough safety data. We could try it and see what happened. So after the second or third dose, the parents had reported that he had worsening of emesis again. So we had concerns that the EOE was worsening. So now gastroenterology is requesting insurance authorization for the increased frequency of dosing with dupilumab. Right now, he's receiving it every 4 weeks for the FDA-approved indication of atopic dermatitis. But I think, as we know, in older patients for EOE therapy, typically it's dosed at weekly intervals. So we're trying to get that approved. And then he's also planned for cord blood transplant in 2024. So I've always wondered, could the use of dupilumab early in some of these primary atopic disorders potentially prevent the development of atopy, similar to, getting lax study of, well, if we intervene early in life, can we prevent some of these atopic issues from developing? And I'm not sure we're there yet with being able to use this drug in these types of disorders on a regular basis. But it will be an interesting question and potential thing to look at in the future. And Len, as I thought my use of dupilumab in Wiskott-Aldrich was original, but I think one of our fellows ended up pointing out to me, hey, Dr. Chen, this actually was published in another patient with Wiskott-Aldrich syndrome. So the group at Phoenix Children's also identified this infant who presented with what was thought to be milk protein proctocolitis and ended up having Wiskott-Aldrich syndrome and was successfully treated with dupilumab because this child also had really severe atopic dermatitis. And I think I might have failed to point out in my last slide. So this is a picture here of some blood in the stools of the child who presented with Wiskott-Aldrich syndrome. I think a fair number of these kids might initially present with what we think is milk protein proctocolitis, but then because of their bleeding dyscrasia, they're bleeding in the gut, and sometimes we never know if it is because they have a little bit of milk allergy or kind of the milk proctocolitis, or if they're just having blood in the stools because of their thrombocytopenia problem. So that's sort of how this patient at Phoenix Children's had presented as well. So moving on, even more recently this year, there were a group of papers that were published in JACI where they identified germline mutations in STAT6 that were a gain of function and led to a severe atopic phenotype. And then a larger group of patients were described in the Journal of Experimental Medicine. And this is one that I think was really an interesting group of papers because, all this time we kind of think of monoallelic disorders as causing increased risk of infection, primary immune deficiencies. But now we're moving on to this burgeoning field of primary atopic disorders and kind of leads us to what a lot of allergists are seeing in their clinics. So patients who have severe eczema, food allergies, asthma, eosinophilic GI diseases. So in the STAT6 gain of function mutations, just to review, a lot of these patients have increased atopic disease, and this is in part because there's STAT6 is constantly getting phosphorylated, even when there is not necessarily IL-4 or IL-13 cytokine induction of these receptors here. And if you have constant phosphorylation of STAT6 or increased or prolonged phosphorylation of STAT6, this will lead to, which is a transcription factor, this will lead to increased Th2 signaling and Th2 pathway function. Oops, sorry, I don't know what happened. So in one of these papers, does this look okay, or do I need to switch the display?
It looks different than before.
Oh,
Oh,
okay.
here we go.
Thank you. Sorry about that. I don't know what happened. So in one of these papers, in the Takeuchi et al. Paper, they describe one of their patients who had this gain of function mutation in STAT6 at position 419. And this patient had increased IgE serum levels, hypereosinophilia, severe atopic dermatitis, and eosinophilic gastritis. And so they kind of, and another way to look at this IL-4, IL-13 or Th2 pathway, in the wild type patients, when you have production of cytokines IL-4 and IL-13, then you get phosphorylation of STAT6, and then STAT6 will upregulate the STAT6 responsive genes. However, in their gain of function patient, you have ongoing binding of STAT6, ongoing phosphorylation, and then development of this Th2 phenotype. And so this just kind of shows you that their patient in this paper. So there's these polypoid formations in the gut, increased eosinophils, this really severe eczema phenotype, and then also fibrosis in the skin that they identified. And so, and then here when they did, they took cells from the patient who had the disorder as opposed to the parents who did not have the gain of function mutation under IL-4 stimulation. There's this prolonged phosphorylation of STAT6 that lasts, beyond the first 15 minutes. So you can see in the parents, the phosphorylation of STAT6 decreases after the first 15 minutes, but in the patient, it kind of continues to be phosphorylated. And then here they also looked at serum cytokine levels in the patient compared to patients who have food allergies on the left side, compared to patients who have eosinophilic gut diseases. And you can see in the patient, there was increased IL-5 levels, but not necessarily IL-4 or IL-13, which I thought was interesting. And then,
Karin, was this a de novo mutation in the patient?
Yes. And then here they've kind of plotted out the IgE levels, going up to, this is the blue triangle, going up to as high as like 30,000 or so. And then just kind of showing you over time all the disease manifestations that the patient presented with and the therapies that they've tried on this patient that were not really responsive. So, extensively hydrolyzed formulations of formula, elimination diets, topical steroids, swallowed steroids, leukotriene receptor antagonists. None of them really, worked very well. And so in another paper that was published in JACI by Talal Shatila's group, they decided to use ruxolitinib, which is a JAK inhibitor, JAK1 and JAK2 inhibitor, on one of these patients who also had a STAT6 gain of function variant. And you can see there's kind of this coarsening of facial features, severe atopic disease, skin infection issues, poor weight gain. And then after treating with ruxolitinib, the skin disease improved significantly and the patient had weight gain as well. And in their assay, they also looked at STAT6 phosphorylation. Sorry, I don't know what happened here. And this patient had increased phosphorylation of STAT6, although all of these papers ran their assays in slightly different ways. And then in the Sharma et al. Paper in the Journal of Experimental Medicine, they had a larger cohort. Instead of just being, one case report, they were able to identify 16 different patients who had defects in STAT6 that were gain of function. All of them had severe atopic disease. Even I think one of them died from anaphylaxis at one point. Some of them had skeletal issues, so almost kind of like a Job syndrome phenotype. A couple of them had vascular anomalies. All of them had eosinophilia. Two of them died, and a few of them had short stature, although I don't know if this was due to lack of weight gain versus truly having, a dwarfism kind of phenotype. And then just pointing out infection issues, half of them had recurrent infections, including recurrent skin infections and molluscum contagiosum. Some of them had recurrent respiratory infections, and some had recurrent viral infections as well. And then in this paper, they were able to look at phosphorylation of STAT6 under IL-4 stimulation. And you can see, wild type, this is what normal phosphorylation or dephosphorylation of STAT6 looks like. But in the patients who had gain of function variants in the red, there was this really significantly increased phosphorylation. And then as an example, in this paper, one of the subjects was treated with dupilumab and had a significant improvement in the severe atopic dermatitis phenotype. And then, Eric Allensbaugh, Konzox, and I, we kind of put together this editorial of these group of papers. And Eric created this really nice figure that shows you where the variants lie on the STAT6 gene. A majority of them were found in the DNA binding domain, although some of them were in farther downstream that were identified as well. And one of the things that we pointed out in our editorial is, well, atopic disease is so common. So how do you know which patients we should do genetic testing for STAT6 gain of function defects? And it seems like, we were thinking probably the ones you would want to sequence that may end up helping you with deciding on therapies that have more severe phenotypes might be the ones you would want to target initially. So these might be patients who have severe atopic disease with onset in infancy, perhaps the ones that have really severe eosinophilic GI disease that are not necessarily responding to standard therapies, the ones that have really unusual disease features like aneurysms, short stature, bone issues, really severe skin thickening and dermal fibrosis. So that might be where you want to target the patients to do sequencing for. But I should also point out that these papers that are describing defects, for the first time in a gene, they're always identifying the most severe patients. So there have been genome-wide association studies that have identified STAT6 variants as being a risk factor for having atopy. So I suspect farther down the line, we may be identifying patients with STAT6 gain of function variants that might have milder phenotypes, and we're just not sequencing those patients because they have milder phenotypes. So just to kind of point out, why do we want to identify these patients who have primary atopic disease? And obviously it's because we can use precision therapies to target the specific defects. We're, as a group in the allergy world, we're increasingly using biologics that target the Th2 pathway, so IL-4. Patients that have eosinophilic issues, we're using IL-5 monoclonal antibodies. Severe eczema and asthma, TSLP, anti-TSLP biologics. And then, in these patients who have defects in the JAK-STAT pathway, we can use JAK inhibitors or small molecule inhibitors, whether it's systemically or topically for treatment of severe atopic dermatitis. And then I had discussed Ikaros defects earlier in this presentation, and I'll go into this a little bit more, but there's this potential for using lenalidomide for treatment of those patients who have Ikaros defects. And then in the most severe patients, we can also be considering hematopoietic stem cell transplant or gene therapy. As an example, in Wiskott-Aldrich syndrome, this is what we're doing already.
Karin, excuse my ignorance. What is lenalidomide?
Lenalidomide is related to thalidomide and is a therapy that's used in treatment of multiple myeloma. And I have a slide, actually, that's a great question. So lenalidomide is almost perfect timing. So it targets this ubiquitin ligase complex. So that's kind of shown here. That includes CRBN. And these defects in Ikaros are what, kind of are important in this this ubiquitin ligase complex. If you don't have a functioning ubiquitin ligase complex, you don't break down Ikaros, and then you can have this gain of function mutation where patients have lymphoproliferation, autoimmunity, and atopy. So, so this lenalidomide can help to degrade Ikaros 1 and Ikaros 3 and helps with treating patients who have issues like multiple myeloma, B-cell lymphomas, but it is a potential for use in these patients who have the gain of function defects in Ikaros. And then here you can kind of see this lenalidomide also can increase IL-2 production. And I mentioned earlier, IL-2 is a cytokine that's really important for T regulatory cells to differentiate and survive. So these Ikaros gain of function patients don't produce as much IL-2 appropriately, and then they have reduced T regulatory cells, which leads to the immune dysregulation that we see. And then patients who have somatic mutations in Ikaros are the ones that are developing multiple myelomas and lymphomas and leukemias. So a lot of these inborn errors of immunity, on one hand, if you have a germline mutation, you'll have a primary immune deficiency or this inborn error of immunity. But on the other hand, if you have a somatic defect in the same gene, you'll have increased risk for malignancy. Or they're finding mutations associated with malignancies in these patients. So just to kind of bring things back together, this is a pretty good review article that just came out by Sams et al. In Current Opinion, Allergy and Clinical Immunology, where they put together a lot of these new defects that are associated with primary atopic disease. And I think here under disrupted cytokine signaling is the STAT6 gain of function mutations. Oh, actually, it's not in here. It's discussed in the paper a little bit, but you're kind of reviewing defects involving decreased T cell receptor diversity, thymic development disorders, where you can sometimes develop an Omen syndrome phenotype, defects in FOXP3 or IPEX-like disorders where you have altered balances of regulatory T cells, including Ikaros 1 here, defects in impaired skin and mucosal barrier function, cytoskeletal abnormalities I talked about with Wiskott-Aldrich syndrome, innate effector mechanisms involving autoinflammatory pathways and increased mast cell degranulation, aberrant T cell receptor signaling, CARD11 pathways, and then metabolic disorders involving glycosylation defects. So some final thoughts that I have. So I've kind of been thinking about, our group of diseases and inborn errors of immunity that, we're kind of increasingly, using genetic testing to achieve a specific diagnosis and guide therapy. But then, the question is which patients should undergo genetic testing. I recently saw a child who was referred to my clinic because through research-based genetic testing was identified to have a defect in TACI, which is thought to be associated with increased risk for developing CVID. However, this child had no issues with increased infections, had normal immunoglobulin levels. The research genetic testing was genome sequencing because the child had some developmental issues, but no infection issues. And so this kind of finding of TACI mutation led to, a whole downstream effect where the child was referred to other specialty clinics that he didn't necessarily need to be seen in. So I think there are a lot of benefits to genetic testing, but sometimes some negative issues as well that can arise from variants that we may not necessarily be using to treat our patients with. So I'm suggesting maybe in our most severe atopic individuals, we should be thinking about genetic testing. And if you're really interested in identifying whether your patient has STAT6 gain of function defects, you want to make sure that the genetic testing panel you're sending off to will actually look at STAT6 because it's such a new disease. Not all of the genetic testing panels might be screening for STAT6 gain of function mutations yet. And then I mentioned, what is the spectrum of STAT6 gain of function phenotype? So we're seeing the most severe ones in publications now, but maybe down the line, we're going to see other phenotypes that might be milder or may have other disease manifestations besides the ones that I talked about. And then lastly, like I pointed out in Wiskott-Aldrich syndrome, which of these classic monogenic immune deficiencies or inborn errors of immunity could benefit from early intervention to prevent food allergies and atopy, similar to what we're trying to do in our general population of infants, introducing peanut early, making sure they have hydrated skin if there's a family history of eczema. What can we be doing for these patients who have known defects? So I hope that stimulates a lot of thinking today as you guys see patients later in the day. And the word of the day for CME is patient. Thanks so much for your attention, and I'll be glad to answer any questions that you guys have.
Karin, if patients have, say, a STAT6 gain of function, and yet there's a broad spectrum of phenotypes from the same genotype, what modulates that? Why is the phenotype different? You were alluding to the fact maybe there are less severe types that are hidden in our atopic population. Why is that? Why do people have the same gene? What modulates it being severe or mild or moderate?
I think it probably, well, if we're looking at molecular mechanisms, it may be the location of the variant or the mutation. So going back to this figure, I kind of pointed out that a lot of the defects that have been described involve the DNA binding domain. And since STAT6 is a transcription factor, it kind of makes sense why if you have a defect in where the STAT6 is binding to DNA and there's aberrant issues, then that might lead to more significant problems because of cell signaling and all the effects that STAT6 may have on other genes. And then, some of the other things that I could postulate would be, in the future, are there issues with STAT6 loss of function? So where defects could have reduced phosphorylation or potentially, increased phosphorylation. So where the phospho-binding site might be, as opposed to variants that might increase your risk for atopy, they may not have as severe of a defect effect on the actual function of this transcription factor. So I think it, kind of all of those things that I listed earlier, whether it's gain of function, loss of function, how it affects the protein function. Though, at least, that would be my theory, and we'll see what comes out of, future papers involving this gene.
Vinod just put a question in the chat box about alopecia, I think, and do you see it?
Not in my view, although maybe if I get out of the.
Maybe this is Vinod here. Maybe I'm asked the question itself, so if you can't hear it. Thank you so much for a good talk, great talk. This is Vinod of the practicing allergist in the community.
Hello.
The question was, I know you talked about alopecia, vitiligo, and some of them having immune defects. Meaning we do get referrals of some patients self-referred to say, we got alopecia, we got vitiligo, what do I do here? So, what patients do you think need an immune evaluation? I don't think everyone does, but is there certain kinds of patients that do? Thank you.
Yeah, that's a really great point. So I think if this is a patient who's developing vitiligo and alopecia, and perhaps if it's early onset, so not something that's happening, much later in adulthood, but children and teenagers who have an atopic phenotype and they're having issues with T cell dysregulation. So those disease features you mentioned, alopecia and vitiligo, where T cells might be attacking melanocytes or might be attacking hair follicles. Maybe those are ones that you would want to consider sequencing. Alternatively, if you're already thinking about targeting, the STAT6 pathway, trying out, topical JAK inhibitors or working with a dermatologist to treat these patients, with some of the therapies that the dermatologists are already using for hair loss and autoimmune issues, that might be an alternate way of going about it. I think it is important when you're thinking of doing genetic testing to discuss with the families ahead of time, like, look, there's, more than 20,000 genes that encode for different proteins in the body, and everyone has differences in the sequence of their DNA. So sometimes it can be challenging to differentiate which of those changes in the sequence of our DNA is just normal human variation versus ones that actually cause disease, to kind of set that stage first before you get results of the genetic testing back. And because sometimes you're going to have to be the one to interpret those results as well. I don't think that was a really great answer to your question, but there are a number of other inborn errors of immunity where patients are presenting with alopecia and vitiligo. So defects in the NF-kappa B pathway are ones in which those patients are having issues. So another thing that you could be doing is looking at immunoglobulin levels and B cell phenotyping. If they have significant defects in terminal B cell differentiation, that might be another clue that this patient could potentially have a monogenic disorder.
Just to follow up on that, would it be then fair to say if they have maybe other atopic conditions or also infection, maybe more for ones to kind of screen for?
Yeah, definitely. I think the classic one that we think about is STAT3 loss of function variants, in which those patients have Job syndrome. And I think, the NIH classification for Job syndrome, where you're looking for bone fractures, not losing your baby teeth. Sorry, I'm trying to go back to that figure, the Josh Milner figure. Where they have connective tissue abnormalities, severe staph infections that are invasive, perhaps not just staph skin infection, but staph pneumonias, those would probably be the ones that you would want to think about sequencing as well. And then obviously, as an immunologist at Seattle Children's and UW, our group is also happy, to provide recommendations to physicians in the community and, give ideas on what potential functional assays might be available clinically before moving forward with genetic testing as well. So I agree with you. I think it's looking at the whole picture of the patient. If they're having increased infections, then that would be definitely a concern that there's a monogenic disorder.
2831,
Thank you.
Any other questions?
If you don't mind, I did have another question. I know you kind of alluded to kind of with the Wiskott-Aldrich syndrome and thinking about using dupilumab as a preemptive or a pre-treatment to see if they can prevent atopic disease. Meaning not that I have, but for you or anyone again in the audience who has experience in terms of dupilumab and pregnancy, and what do we think in atopic families? What do we think is a potential for how that affects with placental crossover, getting into the infant stream? What do we think about development of atopic disease, or does it make any difference or change? Thank you.
So if I understood correctly, sort of, would the use of dupilumab in pregnancy so that there is potentially targeting of the IL-4, IL-13 pathway before a child's even born, would that help to prevent atopic disease in the infant?
But if you want to
Right. Not necessarily as a targeted treatment, but we do have moms who are atopic, and if they do need dupilumab, is there enough of a population there where you can kind of study, or is there data already that you look at in terms of the registry that we know of, what the thoughts are from that perspective?
Yeah, I guess I don't have knowledge of the data out there on dupilumab specifically, but that is a really interesting question, because if these kids are, being born, there might still be some of that monoclonal antibody floating around for the first few months of life. And, would that exert a protective effect on the infant? It's definitely possible. I would have to look at that data, and I'd be open to, if anyone else knows about some of that pregnancy data, I'd be interested. And I should point out that one of the University of Washington Allergy Immunology Fellows, Kelly Colas, she is part of the Quad AI committee that is looking at monoclonal antibody use in pregnant women. So that might be one of those things that Kelly would be interested in looking at. Those are really great questions. Thank you so much.
Thank you.
Well, if no other questions, thanks very much, Karin.
Thanks so much for inviting me, Len. I appreciate it.
Yeah, a very stimulating talk, sort of making at least me think, what first appear like two separate specialties within our field, immunodeficiency and hypersensitivity, seem like polar opposites. A whole new way of thinking about this, that they really are linked together in ways I couldn't have imagined not too many years ago.
Yeah.
Yeah.
Same here.
I don't welcome the tests that the fellows have to take. The science here is overwhelming. But thank you for mastering it so well.
Of course. Thanks, everyone. Thanks for your attention today.
Bye-bye.
Okay, bye-bye.